Well, hello there, and welcome to episode 6 and season 1 of our Winnovations webinar turned podcast series. I'm your host, Dr. Kyle Richards, and we really have a great program planned for this morning. Now, the purpose of these podcasts is to highlight some of the exciting and innovative work being done at the University of Wisconsin in the Department of Urology. We also want to generate discussion within the broader urology community so that we can continue to all work together to make innovative advancements in urologic care. Now, we have some future podcasts in the works, so stay tuned. I don't want to release the details quite yet, but we will be finalizing some additional podcasts coming forward in the spring. But without further ado, I'd like to introduce my guest this morning, Dr. Frank Lin. Dr. Lin joined our department in 2020 after completing his fellowship training at UCLA in female pelvic medicine and reconstructive surgery. In addition to his clinical practice, he is involved in advancing the research of novel therapeutics, including the improvement of robotic sacrocolpopexy techniques, and he's very passionate about his topic for today, which is titled Innovative Approaches to Overactive Bladder. Frank, thanks for joining us today.
Dr. Richards, thank you very much for having me.
Yeah, it's a real pleasure, and I'm really excited for our discussion on some of these novel therapies and treatments for overactive bladder. But first off, Dr. Lin, how did you get interested in female pelvic medicine and reconstruction? And could you give us a brief overview of the specialty?
Yeah, absolutely. Female pelvic medicine and reconstructive surgery, sometimes abbreviated FPMRS, which is a mouthful. It's also known as urogynecology from the gynecology perspective. Deals with incontinence, prolapse, neurogenic bladder, voiding dysfunction, and other types of benign pelvic reconstruction. I was thinking about doing oncology very much like yourself when I was a budding urologist in residency training, but I had great mentors that showed me the way, and I really fell in love with this patient population and improving quality of life.
That's great. And turning to today's topic of overactive bladder, when a patient comes to you, Frank, in clinic with overactive bladder, what's your first-line treatment?
Yeah, first-line treatment for overactive bladder are typically lifestyle management options. These include fluid restriction, so reducing the amount of urine that's actually produced by the body can obviously reduce the amount of urination. Other things such as avoiding foods or liquids that can irritate the bladder, such as caffeinated, carbonated, acidic foods. Citrus can sometimes irritate some patients' bladders, are all first-line therapies. Other things like constipation can also be a player in overactive bladder symptoms.
So what I'm hearing, Frank, is that it's you spend a lot of time talking to patients about sort of modifying their lifestyle. When do you start sort of throwing in other treatments like medications and things of that nature?
Yeah, that's a great question. Most patients have already adjusted their fluid intake, lifestyles, to include that first-line therapy for overactive bladder. Second-line therapy includes pharmacotherapy, or that is medications. And so usually by the time they reach me or one of the urology team members here, we're starting them on a medication.
You know, I think we hear a lot in urology about polypharmacy, and sometimes these patients are on multiple medications. I know most of us know the standard medication for overactive bladder are anticholinergics, but certainly not every patient will respond to those medications. And I guess a couple points that maybe you could address on the anticholinergic data is if a patient doesn't respond to one, is it worth trying a second or a third? Or when do you decide to sort of, move on from, medical therapy, or what's your next strategy, I suppose, when patients seem to be becoming maybe refractory to medications?
Yeah, that's a great question. Yeah, the anticholinergic class is the classic overactive bladder medication for overactive bladder symptoms. These medications can have some side effects, dry mouth, dry eyes, constipation, but can be very effective in reducing urgency, frequency, nighttime urinations, and also urgency incontinence, not making it to the bathroom in time. Many of my patients respond well, but maybe the benefit isn't quite enough, or they're having some intolerable side effects that they really need to have a little bit of a different management strategy. The second type of medication, which is newer to the OAB landscape, is the beta 3 agonist. And there are two medications in that class. There's Myrbetriq, and then there's also Gemtesa. Gemtesa is only about, I think, 3 years old at this point, and Myrbetriq's a little over a decade. These medications target different receptors in the bladder, don't have the classic anticholinergic side effects, that is the dry mouth, dry eyes, constipation, and are overall better tolerated with similar efficacy to anticholinergics. One of the main barriers, and you may be wondering, wow, why don't we just start patients on a beta 3 agonist like Myrbetriq or Gemtesa? And a lot of that has to do with insurance coverages of medications at this point. This newer class is more expensive than the classic anticholinergics.
I think a huge advance probably with these newer medications coming down the pipeline. Now, if patients aren't responding to these medications and they continue to have these bothersome OAB symptoms, what's your next sort of line, or what's your next strategy if it's really impacting their quality of life?
Yeah. So moving on to third line therapy, these are more procedural, more surgical in nature, and there are basically three types of advanced third line overactive bladder management strategies. The first one I'd like to mention is something called percutaneous tibial nerve stimulation. I sort of think about it as acupuncture for the bladder. And that strategy includes placing a small acupuncture needle in the ankle nerve and stimulating that for a number of weeks to see if that can sort of quiet down the bladder symptoms. That's one option. Another option is something called Botox for the bladder. And what we can do is inject Botox, the same Botox that's injected in for cosmetic reasons can be injected in the bladder to calm the bladder down, to prevent spasms and abnormal contractions that can lead to the urgency frequency symptoms that patients have. And the third option is something called sacral neuromodulation. And that's a mouthful, but it's basically similar to placing a pacemaker connected to one of the bladder nerves.
And how do you decide between those options, right? Because it seems like they're all third line, but there's certainly some nuance between the three options there. And you've got that patient sitting there in front of you wanting to know, what should I do, Dr. Lin? What's best for me? How do you help guide a patient through that? And maybe how do you lean in one direction versus the other?
Yeah, so every patient has different expectations and different severity of bother on their symptoms, and that's going to guide them on how invasive of a therapy they're going to pursue. The first one that we mentioned was the PTNS, or an acupuncture. That tends to be a little bit more time investment. You have to come in for 30 minutes for once a week for 12 weeks for the initial induction therapy. For many patients, that's not possible, but some of my older patients are retired or live nearby, and that becomes a really good option for them. No side effects with that. No surgical or anesthetic side effects. There's no medication side effects. And so people that are looking for a more natural therapy option, that's a really great one for them. The Botox option is really good for those that are having some, what we used to call wet OAB, or urgency incontinence symptoms, meaning they're not getting to the bathroom in time. They're starting to urinate before they get to the toilet. And because the Botox medication is so powerful, it can actually prevent some of the bladder contractions. Now, the Botox doesn't last forever, just like the cosmetic Botox also doesn't last forever. So you need typically a re-injection every 6 to 9 months. Some patients are totally fine with that, but others find that to be a temporary fix and not enough durable sort of benefit for them to go through something like that. That injection can be done in the clinic under some local anesthetic in the bladder, or it can be done under some gentle sedation in a more procedural setting. And so that becomes a decision point for patients to undergo. The sticking point with that one is that Botox is sometimes uncommon, but reported where it actually works too well, and it can actually prevent people from emptying their bladders appropriately. That's 1% to 2% of patients overall, but it does happen, and some patients aren't willing to deal with that side effect of that treatment. And the last option we talked about was the sacral neuromodulation, which is like a pacemaker for the bladder, and it's a little bit more involved, and there are two flavors of sacral neuromodulation. One is a rechargeable device the size of a USB drive that's implanted in the lower back area. And the other option is a more permanent battery that lasts 10 plus years. And that device is about the size of an Oreo cookie. And what we do is this device doesn't, the sacral neuromodulation, most commonly known as InterStem, made by the Medtronic company, doesn't work for everyone. It probably works for about 80 to 85% of patients, but we have to actually test it in the particular patient to see if they'll have benefit from it, whether or not it helps them with their urgency, frequency, nighttime urinations, and also leakage symptoms. And so we test it for 2 weeks, and then we decide whether or not it has sufficient benefit, and then we implant the device, the final device. And there's a rechargeable option, and there's also the permanent battery option. That's patient preference as well. The permanent battery option is known as the InterStem X. Just came out about a year ago and has been the device that many of the providers here at UW-Madison have been choosing to implant, as patients prefer that one.
That's a great summary. A lot of wisdom and knowledge in there, Dr. Lin. Thanks for sharing that. And at UW Health Women's Pelvic Wellness Center, we offer all three of these treatments for women. Yeah,
we sure do. Every single one of the FPMRS surgeons is well versed in offering these three advanced therapy options and guiding them through. Some patients don't have good benefit from, let's say, the PTNS or the Botox, and they'll cross therapies to an alternative strategy, or can even combine them. You can use medications plus the PTNS. If Botox doesn't work for you at the first time, then you can switch over to the sacral neuromodulation pacemaker type device, and vice versa. So there's a lot of options out there you can mix and match just to find the right solution for the particular patient.
Now, I mentioned women there, but there are men with overactive bladder as well. Is that true?
That's 100% true, Dr. Richards. Overactive bladder, typically we think of it as an older patient population, but there are young patients that also have bladder symptoms, and we'd like to think that male urology patients suffer from big prostates. However, they can also have overactive bladder symptoms if they've had any sort of pelvic surgery previously, such as a prostatectomy or pelvic radiation. They can have overactive bladder symptoms, and we manage those patients similarly: lifestyle modifications, medications, and finally procedural options.
And I guess you have to sort of tease through, are the symptoms prostate related versus bladder, and then sort of direct treatment based on, are those patients more likely to undergo urodynamic testing to try to sort through some of that?
It's exactly what I struggle with every day in clinic, is trying to figure out if a patient's symptoms are prostate related or if they're bladder related. And sometimes it's a combination of both of those issues. And so you have to talk to the patients about both pathways or treatment modalities. BPH, or benign prostatic hypertrophy, or big prostate. Typically, patients have slow urinary stream, a lot of urinary hesitancy, incomplete bladder emptying. We can do bladder function testing, like you mentioned, with the urodynamics. However, sometimes other testing, such as a non-invasive uroflow and plus a bladder scan, can give us some data without having to do any sort of more invasive testing. Symptoms also play a huge role, and whether or not the patients are complaining of obstructive or blockage symptoms or frequency urgency symptoms. And if you're not sure, these medications can be tried for a short amount of time, 2 to 3 weeks, I'd like to say, and see if they get better. And patients can report back symptom improvement just by trial of medications.
I have to ask this question because it's something that I know is in the guidelines, but is augmentation cystoplasty, is that really a historic operation? Or is that something that, we still should consider in certain subsets of patients?
Yeah, that's a great question. Augmentation cystoplasty for either those with very horribly refractory idiopathic overactive bladder symptoms, or for the neurogenic bladder patient population, used to be performed much more frequently before the advent of chemodenervation, which is the Botox injection. Much less frequently done now. I don't have the statistics on that, but just as a person that's trained through this, just not a very common operation. Now, if you fail medications, advanced therapies, and are still having significant overactive bladder symptoms, that's something you can consider. It is obviously a major operation with its own sort of risks and benefits, but it can be the appropriate choice for some patients. That's different for the neurogenic bladder patient population. Sometimes they just don't respond to even high dose Botox injections, and they may require either an augmentation or a urinary diversion.
So I guess what I'm hearing you saying is that these operations are still being done occasionally for patients that have really failed everything and are quite miserable with their quality of life, maybe have a really small bladder capacity as well. Does that come into the equation as well if you look at their bladder capacity at some point?
Yeah, they can have very small bladder capacities, less than 100 milliliters. And just for reference, the typical bladder capacity is anywhere from 350 to 550 milliliters or so. Probably 400 is about average. So people that are having a bladder capacity of 100 milliliters are at 25% of what normal people might have. They can be even smaller than that, and can sometimes be even associated with some pain or pelvic discomfort.
Now, are there getting back to sort of the medications and pharmacologic agents for OAB? Are there any new meds in the pipeline that you're looking at or aware of that are sort of being studied?
Yeah, my understanding is that there are going to be a number of new beta 3 agonists coming to market in the next couple of years, similar to the Myrbetriq and Gemtesa, that will offer similar benefit for overactive bladder without the side effects of the anticholinergic class.
And then what about novel devices? I know there's a sort of a lot of industry trying to develop certain devices along the lines of sort of sacral neuromodulation and peripheral tibial nerve stimulation. But are you looking at any of these new devices like eCoin, or what are your thoughts on some of these things that are circling out there?
Yeah, you mentioned eCoin, which is a device that is, I think, a couple of years on the market at this point. And it's basically an implantable PTNS option. So instead of coming in once a week for 12 weeks for the office-based acupuncture therapy of your bladder nerve, this device can be implanted at the ankle level, and it's about the size of a quarter or a little battery. And it does the same thing. It stimulates that bladder nerve at the ankle level. And so that's one of the newer implantable options on the market, in addition to all the rechargeable options. One of the other companies that offers a sacral neuromodulation device is Axonics, in addition to the Medtronic InterStem device. And both of these companies offer rechargeable and permanent battery options.
I think it's an exciting time in overactive bladder. There's certainly a lot of research ongoing within, not just industry, but clinical trials, new medications, new pharmaceutical agents. Anything from an installation standpoint that people are putting in the bladder to try to help maybe attack some of the neurotransmitters that are firing on all cylinders, so to speak?
Yeah, Botox is one of those medications that works exceptionally well as an injection therapy. And we typically inject about 100 units into, protocols vary, but 5 to 15 locations in the inside of the bladder. Of course, some patients can have some discomfort with this very small needle that's used with that, or even a little bit of bleeding in the urine. One of the newer sort of research options out there was to actually encapsulate the Botox and actually just be able to instill it into the bladder and let it sit there for some time and actually have it be efficacious. Those delivery modalities aren't quite yet on the market, but I do anticipate that to be in the coming years. One of the other things that's always presented at conferences are other treatment options, either using a viral vector to treat the underlying receptor problem or nerve problem in the bladder. And those are also done by injection therapy typically.
Wanted to just shift gears for a little bit now. Patients that have pelvic organ prolapse, so we've been focusing on OAB, but a lot of patients that with pelvic organ prolapse can also have concomitant OAB symptoms. So what's your approach to that patient that has a significant prolapse that may be contributing to their OAB? Is that where you might consider some sort of surgical intervention?
Yeah, great question. A lot of my patients that do a robotic prolapse surgery to fix their prolapse will report, wow, my bladder symptoms are significant, noticeably better in the months after surgery. And we do find patients that, they have some clinical prolapse on examination and have overactive bladder symptoms. And so We can try medications just the same, try the OAB, overactive bladder pathway, and move forward on that. Sometimes I might suggest using a non-surgical management of their prolapse, such as using a intravaginal pessary, which is kind of like a support device for vaginal prolapse, and see if their symptoms get better from that perspective. They might report not having any prolapse symptoms such as a bulge or pressure in the lower pelvic area or pain. They might not notice having a mass that sticks out, but sort of reducing or pushing that prolapse back might be helpful. The other thing that we like to try a lot is vaginal estrogen. Topical vaginal estrogen cream, even a small amount, can help bladder symptoms, particularly in postmenopausal women. There are a lot of estrogen receptors in the vaginal tissue, the urethra, as well as the bladder, that can have improvement of their symptoms from a topical vaginal estrogen cream that's applied 2 to 3 times a week.
So how do you decide then, Dr. Lin, who is a good candidate for a robotic prolapse surgery? And then maybe follow up on that is sort of take us into some detail about what a robotic surgery might look like. And because I think that's pretty innovative and very exciting work that you're doing in the operating room.
Yeah, prolapse is, I like to think of it, or I explain to my patients that it's a hernia coming from the vagina, typically associated with a history of vaginal deliveries. My typical patient is over 50 years old, maybe was diagnosed with some mild vaginal prolapse years ago and has slowly but surely worsened as they've aged. I think of the support structures of the vagina have been weakened through the initial childbearing, and that the support structures with age and gravity have slowly deteriorated. Patients have to be complaining about prolapse symptoms. They have to really be wanting some sort of surgical or management option. And similar to the overactive bladder pathway, there's a prolapse pathway, which includes conservative management such as observation. If it's not bothering you too much, leave it alone. There's pelvic floor physical therapy options, including physical therapists that will help you strengthen the pelvic floor muscles and give you a better understanding of your own pelvic anatomy. Mentioned previously was the pessaries for those patients that don't want surgery, can't have surgery, or are waiting to have surgery. A pessary, which looks like a silicone dish, there are many shapes and sizes for these, can be placed and used as a bridge until definitive surgical management. And then finally, there's surgical options. There are both reconstructive and obliterative options. There's transvaginal and transabdominal options. And I specialize here at UW-Madison, a transabdominal laparoscopic robotic-assisted sacral colpopexy, and that's a mouthful, but basically using the robotic Da Vinci system and supporting the vaginal walls and fixing that prolapse for patients.
And that's done with mesh?
That is correct. Yep, that's correct. It's done with an FDA-approved synthetic mesh. These are similar to hernia meshes that are used for common inguinal or umbilical hernias. The mesh that's put in is FDA approved and is sort of very different from the meshes that had a lot of controversy several years ago, in that they're placed through the abdomen and not through the vagina.
Well, that's really exciting work. And I think we're nearing the end of this podcast. I do want to thank Dr. Lin for sharing with you all this innovative knowledge and your innovative approaches to overactive bladder. We were able to touch on some prolapse and how that relates to overactive bladder as well. It's really been a pleasure having you, Dr. Lin.
Dr. Richards, thank you very much for having me.
And we look forward to having some more podcasts in the future. So look out for future releases coming out this spring, and there'll be more to come. So signing off, I'm Dr. Kyle Richards, your host of Winnovations. I want to thank the Department of Urology here at UW-Madison, UW Health, including our chair, Dr. Stephen Nakata, and hope you all have a great rest of your day.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.